Hi everyone, welcome and thank you for joining us for today's web seminar, Dementia Workforce Development, 2 Models to Prepare for the Future. We'll be getting started in just a few minutes. Today's web seminar is part of the National Alzheimer's and Dementia Resource Center web seminar series sponsored by the Administration for Community Living. Copies of the slides are available on the left of your screen under the tab marked Resources. Slides are here. And under the tab marked CE application here, you'll find information about continuing education credit for today's event. Please note it will take us up to 30 days from the date of your application in order to process and issue your CE credit. Also, please also note that if you're not logged directly to this web seminar using the URL that we sent to you when you registered, unfortunately you will not be eligible for continuing education credit because we'll have no way to track your electronic attendance. So if you'd like to receive continuing education credit, please go back to your office, workstation, or personal computer and log in using your personalized confirmation URL that you received after registering. During the event, you can type in questions anytime using the Q&A box. We'll hold those and presenters will address them at the end, at the last 15 minutes of the presentation. And now I'd like to welcome Sarah Schuman of the National Alzheimer's and Dementia Resource Center.
Thanks so much, Betsy, and thank you everyone for joining us today for the webinar, Dementia Workforce Development, 2 Models to Prepare for the Future. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Good afternoon, everyone. I want to thank you so much for taking the time out of your busy schedules to join us to learn about the important work that's being done by Dr. Erin Emery-Tiburcio at Rush University Medical Center and Katelyn Marschall with the Wisconsin Department of Health Services. We're very grateful that they're taking the time to share their models with us so we can learn more about preparing our workforce for the future. So with that, I'll give it back to you, Sarah, so we can start. Thanks.
Great. Thank you so much, Erin. So as you heard, today's presenters are Erin Emery-Tiburcio and Katelyn Marschall. Dr. Erin Emery-Tiburcio is an associate professor in geriatric and rehabilitation psychology at Rush University Medical Center. She's the co-director of the Rush Center for Excellence in Aging and Catch On, the Geriatric Workforce Enhancement Program based at Rush. We also have with us today Katelyn Marschall, who is the Dementia Care Specialist at the Wisconsin Department of Health Services. She manages the Dementia Care Specialist Program and federal and state grants related to Alzheimer's disease and related dementias. Katelyn also supports the work of the Wisconsin State Dementia Plan. At this time, I'll turn it over to our presenters, and we'll start with Dr. Erin Emery-Tiburcio.
Thank you so much, Terry. I'm grateful to be here. I hope that we're able to get our sound issues resolved, as it sounds like there are a couple folks that are having some sound issues, so hopefully we'll be able to get that resolved, and hopefully y'all can hear me. So wanted to start today by talking about something that I'm sure that most of the folks who are on this webinar today are aware, that there are an enormous number of Americans living with Alzheimer's disease, 5 million currently, and growing at an alarming rate. What that means is that not only do we have 16 million Americans providing unpaid care for people with dementia right now, that number is growing and our workforce is unprepared. In fact, half of primary care docs don't believe that they're ready to address these needs. And I know that to be true, as I was just on a conference call on Monday with some colleagues talking about how are we going to address dementia in primary care, because we don't have enough memory clinics to be able to meet these needs. We don't have enough specialty care providers, neuropsychologists, neurologists, geriatric psychologists, geriatricians, and a whole host of other folks, because treating individuals with dementia and assuring their quality of life requires an entire team. And so as we look at what that means, not just what happens inside the health system, but as we look at just the sheer number of activities of daily living that require more assistance for those with dementia than caregivers of other people. Everything from getting in and out of bed, bathing, showering, getting dressed, feeding, getting to and from the toilet, dealing with incontinence, all of those things, individuals with dementia require more care. And so as we think about who's providing that care, turns out the vast majority of care for older adults, and particularly those with dementia, is provided by family. And as we've known for years, the majority of those folks are women. Many of them are over 65, as many are spouses, and or at this point, as we are living so much longer, it might be a 65-year-old daughter providing care for her 85-year-old mother. And a lot of those folks have very low income, so under $50,000 for the household. And because many times the person who is providing the care is living with the individual with dementia, that means we've got a household of at least 2 people living on less than $50,000 a year, which means that there aren't a lot of additional resources for providing care, for meeting needs in the home. And so in addition to those informal care providers, the number of direct care workers is growing across the United States. Nurses aides, home health aides, personal and home care aides. And these folks, on average, have very little, if any, dementia training. And even when we provide dementia training, there is such high turnover in this group because this is really hard work to do. As we were just seeing, there's a lot more assistance to provide for individuals with dementia. And as we ask those folks to provide that level of care with very little training and with very little money. So of course there's going to be high turnover. We're not going to get people to stay in those jobs if we're not adequately paying and adequately compensating those folks in multiple ways. So we need to be providing that training and providing it over and over and over again. So in addition to the folks that are providing care in the home, we have about 5% on average, depending on the kind of provider, 5% of the number of geriatric healthcare providers that we need. And the numbers are shrinking. It's frightening to think about the vast number of older adults, and we've all seen the demographic slides. I didn't even bother to include one here because we've all seen the demographic slides that the number of older adults is increasing, which means the number of individuals with dementia is increasing as the base rates there are 50% or greater depending on the kind of dementia. And we have so few trained individuals to take care of those folks. I am appalled that I am the only board-certified geriatric psychologist in the state of Illinois. That's not a badge of honor. That's terrifying. It means that we don't have enough folks who are adequately trained in any of our specialties. So to try to meet those needs, the Health Resources and Services Administration, my apologies, HRSA, have pooled all of their geriatric workforce money and created Geriatric Workforce Enhancement Programs, of which there are 48 around the United States and territories, as well as Geriatric Academic Career Awards, or GACAs. And as we think about the idea that the vast majority of research that is done in the United States doesn't include, or worldwide for that matter, doesn't include older adults because they're messy. The vast amount of research does not include people over the age of 65, people with multiple chronic conditions, people on multiple medications. Well, that's all older adults. And so in order to be able to have research so that we know what's effective in medications, in behavioral interventions, in anything related to healthcare, we need to be able to build academic career professionals. And so there are GACAs and there are GWEPs. The Geriatric Workforce Enhancement Program, as we lovingly call it GWEP, or depending on where you are in the U.S., some people call it GWEP. At Rush, we named our GWEP Catch-On, which of course everybody has to have a catchy acronym, Collaborative Action Team Training for Community Health Older Adult Network. We hoped that it would catch on. Yes, it's quirky, I get it. And we have a whole host of activities. GWEPs are required, all 48 of us are required to provide education, to educate the workforce about working with older adults, and that's everyone from high school on up through licensed professional. And the other side of that is transforming primary care and trying to create age-friendly primary care. And there are a lot of different ways that GWEPs are doing that across the nation. The way that we are approaching all of those activities, and I'll talk about each of these activities a little bit more in a minute, but the way that we're approaching it from a big picture standpoint is trying to create age-friendly health communities. the John A. Hartford Foundation funded the Institute for Healthcare Improvement, the Catholic Hospital Association, and the American Hospital Association to come together and take a look at all of the interventions that have been demonstrated to provide significant health outcomes for older adults and boil that down into a framework that can be implemented across the country in every health system, in every primary care. And what they came up with was the 4 M's. What matters to older adults, so that's what matters to them in their life and how can healthcare help support that, as well as advanced care planning, advanced directives, medications, assuring that we are having as few medications as is absolutely necessary, particularly minimizing those that are high risk, as certain medications become much higher risk as we age. Mobility, keeping people moving, that's one of the key pieces that keeps people in their homes. And mentation, which includes dementia, delirium, and depression. So when we address these 4 M's in the health system, and the original Institute for Healthcare Improvement concept here was that we would implement these 4 M's inside the health system. But what we know is that the 4 M's, or rather the healthcare, doesn't just happen inside the 4 walls of the health system. We need to be thinking much more broadly. We need to be thinking about age-friendly health communities. And particularly as we think about individuals with dementia, that addressing what matters to them is critical, assuring that the medications that they are taking are not exacerbating their cognitive decline and or getting in the way of what matters. And folks who are trying to manage medications on their own may have a lot of difficulty with that, with cognitive impairment. And certainly keeping people moving. We've got a fair amount of research now demonstrating that people who are much more physically active are less likely to get dementia in the first place, and slowing the cognitive decline. And of course, depression and delirium, as they relate to depression, delirium being the acute onset of cognitive impairment related to most often an infection or medication or something that is generally reversible. That individuals with dementia are at highest risk for. So somebody who has dementia is at highest risk for getting a delirium and at high risk for having depression. So particularly in the context of dementia, we really need to be thinking about the 4 M's, and we need to be thinking about them not just inside the health system, but in the community as well. So all of our catch-on activities are in the service of creating age-friendly health communities. So we've created a fair amount of online education, which for those of you who are looking for additional continuing education, we offer free CE online. And we have some of our online modules are specific to dementia, so Dementia Basics, which we have a version available for the community as well in English and Spanish on our website. Also person-centered care for people with dementia, behavioral interventions for challenging dementia-related behaviors, and we just came out with a whole new suite of 4M modules on dementia, delirium, depression, caregiving, mobility, and medication. And we created these intentionally we have 2 versions. There's the first part of it that is something that everyone who works in any part of the health system should know, from administrators to your front desk to the people who empty the trash, what they should know about each of these 6 topics. And then an additional element for clinicians, people who are actually providing direct care to older adults. And all of that is available for free continuing education. We've been trying to do a fair amount of online education, and particularly in the era of COVID, this has become critical, as it has been impossible for us to do in-person trainings. That said, we have created in-person trainings, and over the last couple of years have provided what we're calling Equip the Trainer workshops. And the idea is that we want to bring in administrators, supervisors, folks who are responsible for providing training to their organizations, whether it's long-term care or community-based organizations or anybody who's working in adult daycare, anybody who's working with individuals with dementia, that we can provide you with a whole suite of tools and background about dementia. And we've been tweaking this over time over the last few years. And we have a couple of different versions of this training. We're working on making those trainings virtual as well. If you're interested in having one of those virtual trainings for your organization, please don't hesitate to reach out to me. We'd be happy to talk with you about that. We also have a whole suite of educational opportunities within our GWEP. We have monthly learning communities that are focused on the 4 M's. Each quarter focuses on 1 M. And within the mentation M, we focus on dementia specifically. But even as we're talking about all of the M's, as I was just highlighting, all 4 M's are critically related to meeting the needs of older adults with dementia, and thus individuals who are in the dementia workforce understanding those. And the learning communities are targeted at primary care, anybody who works in primary care. So if any of you are interested in our 2021 learning community, please don't hesitate to reach out. We also do a fair amount of education in our university. So Rush University is a health sciences university that has a medical school, nursing college, and a college of health sciences with a number of different professions, and we provide a fair amount of 4Ms training in that regard as well. We're in the process of developing what will probably end up being 15 or 16-hour certificate for foundational competency in geriatric mental health that will be targeted toward licensed social workers, psychologists, and psychiatrists, folks who haven't had geriatric training, who are licensed to provide services but haven't had geriatric training. So we're in the process of putting that together, and this is based on initially on the foundational competencies for geropsychologists that we published a couple of years ago, and are now expanding that to include the critical competencies for social workers and psychiatrists as well. We also have a health education about LGBT elders, or HEAL program, that includes the 4 M's and focuses on, there are 6-hour trainings that are available for continuing education. If any of your staff is interested in learning about LGBT elders and how to most effectively meet their needs, please don't hesitate to reach out. We'll be happy to talk with you about that. With regard to our primary care transformation, again, our intention is to create age-friendly health communities. And so we have, at Rush, we have our primary care providers partnering with community-based organizations. We also have primary care partners downstate Illinois in Carbondale, and actually around the entire southern part of the state, as we have Shawnee Health Alliance and SIU Family Medicine as partners. And then in Tennessee, Cherokee Health Systems in eastern Tennessee as federally qualified health center primary care partners. And through those partnerships, our intention is to be able to partner primary care with community-based organizations to create those age-friendly health communities. And one of the ways that we do that is through our Caregiver Identification and Wellbeing Project in the hospital at Rush, identifying caregivers. One of the things that makes it really complicated in managing the needs of individuals with dementia is that we don't know who the primary caregiver is even in the hospital. So if somebody comes into the hospital from a nursing home, from home, identifying who that person is, and then if that person even in the hospital has had an acute change and needs to go home, is that caregiver ready, willing, and able to be able to provide the level of services? I used to do a fair amount of work in physical medicine rehab, and we would talk to, the patient's wife on the phone, who would say, yes, absolutely, I'll be his caregiver, and I'm going to come in for family caregiving. And she shows up for family caregiving in a wheelchair with an oxygen tank, and her husband requires physical assistance. So a huge piece of meeting the needs of individuals with dementia in particular is identifying those caregivers and assuring that they are ready, willing, and able to be able to do that. And once folks are out in the community, our Closing the Loop program connects our community-based partners, identifying needs and assuring that those needs are getting fed back into primary care. So reaching from primary care out into the community, but then also reaching from community back into primary care to assure that we are closing that loop. Also, to facilitate safe medication management at home, we have partnered with the University of Illinois at Chicago Pharmacy School to create the Safe Home Opioid Management Education Program. A number of older adults in the community on opioids, including those with dementia. And so this program is about educating people on how to use naloxone. So we educate the direct care workers, and the direct care workers are then empowered and educated to train family members and older adults themselves on how to use naloxone, particularly in the case of dementia. If this was actually has been incredibly valuable to our direct care workers, who have now said that individuals are feeling so much safer at home knowing how to use naloxone, particularly if an individual with dementia were to take more medication than is safe to do. And because these direct care workers are the eyes and ears inside the health system or inside the home, then it's really critical to assure that those eyes and ears are effectively trained to listen well. And that's often not part of the training. In fact, it's almost never part of the training. So we've developed an active listening training for direct care workers to learn how to listen to their older adult care recipient, and particularly those with dementia. We're going to be working on a version 2 or a step 2, I suppose, to help folks to listen to what's driving the behaviors of individuals with dementia who are unable to effectively verbally communicate those needs. And lastly, our Dementia Friends and Dementia Friendly Community efforts. So Dementia Friendly Communities are communities that want to come together as a community, identify local stakeholders who are interested in assuring that the community can meet the needs of individuals with dementia so that people with dementia feel included and supported in the places that they live, work, and play. And so the community defines for itself what it needs in order to be dementia friendly, and utilizing existing resources and existing people who are in the community to implement a plan to meet the needs of those with dementia. And at Rush, we are the host of Illinois Cognitive Resources Network, which is our state technical assistance for Dementia Friendly America, and Catch-On is a primary supporter of that work. So we currently have 9 Dementia Friendly Communities in Illinois certified by Dementia Friendly America. 3 more in process, and we continue to grow. It's actually been sort of phenomenal to me that we've been able to grow during COVID, but are very excited to be able to build that and toward that effort to assure that there are more folks in the community who are aware of what dementia looks like and how to be sensitive to the needs of individuals with dementia. There's an international program from the Alzheimer Society called Dementia Friends. You can get training. It's 1 hour online, couple of videos that you watch, and the idea is that it turns understanding into action, learning small ways to help. We've expanded, with Catch-On, we've vastly expanded the number of Dementia Friends in both Illinois and Tennessee. Tennessee only had a handful before Catch-On started to get involved, and now we've expanded that as well. So this is a great resource for lay people in the community to get certified, and if you want to become a Dementia Friends champion to kind of bring in more folks into the community, there are opportunities for that as well. So my contact information is here on the screen. More than happy to receive emails from anyone if you're interested in having any of these programs be involved where you are and or helping you to find the GWEP closest to you, because there might be some great opportunities that are offered to you locally from another geriatric workforce enhancement program. So with that, I'm going to turn it over to Katelyn, and we will address some of the questions that I'm seeing popping up toward the end. Katelyn, I'm going to hand it over to you.
Great, thank you so much. Good afternoon, or I guess good morning, depending on where you are. I want to thank the National Alzheimer's and Dementia Resource Center and the Administration for Community Living for inviting me to speak on this webinar today. I'm going to be sharing information about Wisconsin's Dementia Care Specialist Program, which is a community-based program designed to serve people with dementia and family caregivers through aging and disability resource centers and tribal partners. I want to start our journey together addressing the purpose and need for the Dementia Care Specialist Program. This slide shows a map of Wisconsin with the percent of the population that were ages 60 and older in 2015. And we can see that in the majority of the counties, older adults make up at least 20 to 30% of the county population, which is illustrated by the light blue color. And in the northern and central parts of the state, older adults made up 30 to 40% of the county population, which is illustrated by the medium blue color. This slide shows the same map, but for 2020, and we can see that the demographics of Wisconsin are changing, and that the percent of older adults is increasing, especially in the central and northern areas of the state. And finally, this slide shows the same map with projections for 2040,
we can see that the majority of counties in the state have an older adult population above 30%. And the purpose of showing these slides is not to incite panic about the future, but to help us to prepare for the needs of our community so that we can support older adults and their families. We know that the #1 risk factor for Alzheimer's disease and related dementias is age. And with the aging population in Wisconsin, it's logical to project that the number of people with Alzheimer's disease and related dementias will also increase. So DHS created the DCS program to provide information and support to people with dementia and family caregivers. So now that we understand a bit about the aging demographics in Wisconsin, we have some context for the history and creation of the DCS program. So in 2013, the DCS program was piloted using state funds in 5 Aging and Disability Resource Centers, or ADRCs. In Wisconsin, ADRCs are the one-stop shop for accurate and unbiased information on all topics related to aging or living with a disability. ADRCs provide information and resources related to in-home personal care, housing options, home modifications, adaptive equipment, transportation, caregiver supports and respite, Medicare, Medicaid, Social Security, and long-term care. And as the need for specific information and supports for people with dementia and caregivers increased, the ADRCs seemed like a good fit to house the DCS position. Due to the success and growing support of the DCS program, in 2014 the program was expanded by 11 ADRCs. And then in 2015, the program was expanded to fund tribal dementia care specialist positions within 3 American Indian tribes, including Menominee Indian Tribe, Oneida Nation, and St. Croix Chippewa. There are 11 federally recognized tribes in Wisconsin, and in regards to ADRC programs, tribes are able to choose if they want to be a full governing partner with the county, which means that their tribal members are served by the ADRC in their area, or the tribe can choose to employ an Aging and Disability Resource Specialist, or ADRS, who provides specific ADRC services for tribal members. So in the 2017-2019 state budget, the program was expanded further by 5 ADRCs. Additionally, the DCS program became a permanent part of the state budget, meaning that the appropriation did not need to be re-added for every state budget in the future. And then finally, in the current budget cycle, the DCS program was expanded again to include 8 additional positions for ADRCs and 1 position for new tribes. So as the program stands today, there are 33 dementia care specialist positions, 34 out of 48 ADRCs, and 5 out of 11 tribes have an assigned DCS position. And since some ADRCs cover multiple counties and some DCS cover multiple ADRC service areas, we are able to cover 56 out of the 72 Wisconsin counties and 5 tribes. So this is another map of Wisconsin with the purple service area representing counties that have a DCS in the ADRC service area, and the green boxes represent a tribe with a DCS. As you can see, there are still some counties that do not have access to a DCS position, and several tribes lack access as well. As we continue to discuss program expansion and access, we want to make sure that we address equity concerns that may come up. So for example, in Milwaukee County, they have the largest population with approximately 950,000 residents. So Milwaukee may need more than 1 DCS position to address needs. Additionally, the ADRC of the North is comprised of 5 geographically large counties in the rural northern part of the state and may need more than 1 position to cover all 5 offices and the large geographic space. Our hope is to have a statewide DCS program so that everyone has access to DCS services in the future. So I want to shift now into talking about what the dementia care specialists actually do, and they do a lot. When I talk about the DCS, I frame their position, roles, and responsibilities in 3 pillars. The first pillar is that the DCS increase the dementia capability of the local ADRC staff and other county and tribal agencies. It is not the expectation that the DCS will work with every family who walks through the door of an ADRC or calls an ADRC with concerns about dementia. This would be unsustainable, and DCS in service areas with a large population would quickly become overwhelmed. Instead, the DCS train ADRC staff on memory screening, types of dementias, and communication strategies to ensure ADRC staff feel capable to serve customers who are living with dementia. The DCS will also train other county and tribal agency staff, including veteran service officers, public health staff, adult protective services staff, public transportation, and others. The second pillar of the DCS program is to facilitate local efforts to build dementia-friendly communities. Again, the Dementia Care Specialist cannot do this work alone, and so the DCS often work with a coalition or a group of volunteers. DCS will coordinate dementia-friendly business trainings, work with partners to facilitate memory cafes and support groups, and they do a lot of outreach and community education in the goal of reducing stigma around dementia and to educate people about the diseases and community resources. The third pillar is that DCS support people with dementia and family caregivers. The goal of the DCS program is to help people with dementia and family caregivers to remain active in their community and to live in their homes for as long as they feel safe and supported in doing so. To accomplish this, the DCS will hold family meetings, provide education, information, and referrals to supports, and provide evidence-based and evidence-informed health promotion programs. The DCS have a menu of programs that they can choose from to provide, including the New York University Caregiver Intervention, Savvy Caregiver, Music and Memory, Spark, Boost Your Brain and Memory, Virtual Dementia Tour, and others. There is a lot to accomplish within these pillars, and we are thankful to have a great group of DCS professionals who are doing this work. So this slide includes the program data from 2019. The 33 dementia care specialists serve 2,800 people, which includes both people with dementia and family caregivers. Although keep in mind that many of the ADRCs that were awarded positions during this state budget cycle were not able to hire their DCS until late 2019 or early 2020. Based on this data, a customer has approximately 3 contacts per customer, which illustrates the amount of follow-up that DCS do with the customers they work with. DCS serve customers of all ages, as you can see here, although the average age is 76 years, and the majority of customers are female. The DCS do a lot of outreach, reaching 46,000 people in 2019. And as I mentioned before, DCS train ADRC staff on how to do memory screens. And so in 2019, ADRCs provided 3,200 memory screens to customers. Now onto some qualitative data. So I often hear testimonials and stories that the DCS share with me, but the one I'm going to share with you really drives home the importance and impact of the DCS program. So this testimonial comes from a family caregiver who was caring for his mother, who was in her early 80s and living with Alzheimer's disease. So the testimonial from the customer says, "It was a forward-thinking development for the state of Wisconsin to create and fund those positions just a few short years ago. I am sure you are aware that at the time, Alzheimer's and dementia research funding nationwide lagged well behind that of the major diseases, while at the same time the cost of care of those afflicted far exceeded that of other illnesses. Addressing dementia is and will continue to be the journey and major healthcare battle of our time. As a baby boomer and son of an elderly parent now slipping away into dementia, I have had fairly significant exposure to our system here in Wisconsin while advocating for the best care possible for my mother. While we began down this road several years ago, one of the very first and most valuable resources I was drawn to was the Dementia Care Specialist at the ADRC office. She took time out of her busy schedule to see me on short notice without an appointment and to discuss at length different options and resources available to me as a family caregiver and potential long-term caregiver.
She was very helpful in offering her professional insights and pointing out the value to both patient and family of keeping a person in their home for as long as possible. Utilizing some of these strategies and resources the DCS provided or offered that day allowed us to keep our mother independent for quite some time until circumstances of her condition compelled us to seek other long-term care options. Nonetheless, my siblings and I are thankful that such a resource as the DCS was available to us and our mother in her time of need. As a former law enforcement officer, I am also aware of other important functions the DCS role plays throughout the state, such as consultation and training for families, caregivers, healthcare professionals, public safety workers, and the business community. In the coming years, the transmittal of this kind of knowledge will be increasingly valuable and important to a growing segment of the population. If, via the expertise, advice, training, or other work conducted by a DCS keeps just a few dementia patients independent in their own home each year and out of the mainstream long-term care facilities, it more than pays for the DCS position. So the DCS program is very popular in Wisconsin and is often covered in local news outlets. This slide and the next slide provide examples of articles from a basic search. And I want to talk briefly about the news stories on this slide. The first story highlights the work that one of the DCSs has been doing in a local school district. The DCS have been using the Dementia Friends curriculum, which actually Dr. Emery-Tiburcio provided an overview of in her presentation. And so the DCS have also been using this curriculum to teach about dementia at the local high school. So using Dementia Friends curriculum has been a great resource to the DCS, and it has been relatively easy to adapt to a school setting. And then the second article on this slide highlights a visit that the Wisconsin Lieutenant Governor Barnes made to an ADRC just before the passage of the most recent state budget. And ADRC leadership and staff educated Lieutenant Governor Barnes about the work of ADRCs and the role of the DCS position. So since the creation of the DCS program, there have been several great resources developed, which I've included on this slide and will highlight. The first resource is the Memory Screening and the Community Manual, and it's the manual that the DCS are trained on to use to train ADRC staff. The manual includes the protocol that we use to conduct community-based memory screens. The second resource is the DCS webpage on the DHS website and contains general information about the program, including the map of DCS service area coverage that I showed earlier. The third resource is the Online Family Caregiver Training, which is a set of online modules that provide basic information about dementia and dives into behavioral and psychological symptoms of dementia and how family caregivers can address these behaviors. And this training was developed under an Alzheimer's Disease Initiative Specialized Supportive Services grant from the Administration for Community Living. The next resource is the Dementia Friendly Communities Toolkit, which is a tool that communities can use to start incorporating dementia-friendly principles into their communities and develop dementia-friendly business trainings. The next resource is for the Wisconsin Dementia Resource Network, or WDRN, which is a resource led by our partners, the Wisconsin Alzheimer's Institute, which convenes leaders in dementia care from around the state to discuss innovative programming. Many of the DCS have presented during WDRN webinars, including a program like Reelin' in the Years, which is a fishing outing for people with dementia. The last two resources are program reports. The first link is the state level report, and the second link is a report from Dane County, which is the Madison area. That's their DCS report. So before I end my time here with you, I want to give kudos to my colleagues, Kristen Felton and Eric Grosso. Kristen is the dementia specialist in our office, and the DCS program was actually her brainchild, and I'm so honored to carry on the management of this program. And Eric Grosso is the demographer in our office, and he provided the maps that I shared earlier in my presentation. So thank you all for your time and attention, and here's my contact information, so please feel free to reach out to me via email if you have questions or comments. And now I will turn it back to Sari.
Thank you so much, Katelyn and Erin. What great presentations. We do have questions coming in from participants, so I will get to those. You can enter your questions into the question and answer box on your screen. So you can keep doing that as we start moving through these. So there's a few questions for both of you and some that are more individualized. So I'll start off with a question for both of you. You can answer as it relates to your specific programs. So can you talk a little bit about how records and client progress is monitored and tracked by care teams? How is information communicated between those who are working with your clients and their healthcare team?
Katelyn, you want to start on that one?
Sure, I can go ahead. So as far as tracking progress with customers, we do have a client tracking system that we use to track progress and outcomes of clients. And then to address the second part of that question in regards to collaborating with healthcare partners, that typically happens in the Dementia Care Specialist Program when memory screening occurs, so either when a dementia care specialist or another ADRC staff member provide a memory screen to a customer. After that memory screen results, after they receive the result of the memory screen, the DCS or the ADRC staff can refer the customer to their primary care provider with a letter just explaining what the memory screen is, what the result was, and if it's recommended that there's a diagnostic follow-up, the DCS can provide that as well. And we always encourage the dementia care specialist to work with the healthcare provider in making sure that they provide coordinated information and coordinated care.
That's some wonderful coordination. This is Erin. So that is an ongoing challenge when we're talking about connecting community-based organizations with healthcare providers, and we've been trying to work on increasing those opportunities, particularly from our direct care workers. We do have a program at Rush that utilizes a program called NowPow, which is a independently curated list of community available services that Rush utilizes. We provide referrals to community-based organizations, and then through NowPow, we're able to get a closing the loop to let us know whether that individual accessed that resource. So that's one way that we do it. Our Closing the Loop program is another way, as we have provided connections directly to community-based organizations and patients' consent to us continuing those conversations to assure the continuity of care. So it's operating a little bit differently in each of our communities. And I think the key piece there is also not only empowering folks who have that information, like direct care workers, to be able to share that information with families and the healthcare providers. So a piece of that is empowering and assuring that they know they can do that. And the second key piece that, number one, is dependent upon, of course, is the patient consent to be able to do that. Most older adults would say, yes, I want my whole team to talk to each other, and they get irritated when we don't. And so there's a lot of opportunity to be able to do that as long as we have those two pieces in place.
Great, thank you. Erin, during your presentation, a question came in about whether you have any training about the differences between different neurocognitive illnesses, Alzheimer's disease, Lewy body, frontotemporal degeneration.
Yes, interestingly, the first time we gave our Equip the Trainer workshop downstate Illinois, that was one of the key pieces of feedback that we got, that people wanted that information. So we have incorporated an hour of training into that workshop. And at some point, I'll have to check with our dementia training team to determine whether they have made that an online training yet at this point. We don't have it live anywhere, but yes, that is absolutely part of our Equip the Trainer training program. So happy to be in connection with anyone if they're looking for that kind of training.
Great, thank you. Katelyn, we have a few questions that came in that are asking what particular memory screening do you use for the DCS folks? What one are they using in the community? And what competencies do the DCS need to have before they come on board?
Yeah, those are great questions. So to address the first question, we typically use the mini-cog and animal naming as a joint tool for memory screening. And again, those resources are in the memory screening and the community toolkit, or manual rather. And so we typically use animal naming and mini-cog. There are some adaptations depending on the customer. For example, for people with intellectual and developmental disabilities or IDD, we do use a different screening tool just because typically those individuals may not be able to respond to the mini-cog or the animal naming typical procedures. And then as far as the requirements for becoming a dementia care specialist, we don't have any requirements on sort of the credentialing necessarily. Typically we have a lot of social workers, we've had nurses. We do require that the dementia care specialists have a bachelor's degree, a minimum of a bachelor's degree. But again, we have a lot of social workers, we have nurses, but then we also have a wide variety of folks that bring a lot of different backgrounds. We've had individuals with MBA or folks who have worked at the county level government for a while and move into the position. So it's a wide variety of folks who bring a diverse perspective and background.
Great, thank you so much. So can you talk a little bit, oh sorry, the question just jumped off the page, sorry. Can you talk a little bit more about the memory screening in the community manual and how people get their hands on that, Katelyn?
Yeah, sure. It sounds like it's a popular tool. So on the presentation for today, you should be able to download the presentation. One of the links on the presentation is the link to the memory screen manual, and that will bring you to the Department of Health Services website, the Wisconsin Department of Health Services. The other thing you can do is I'm sure you can probably just type into Google Wisconsin Department of Health Services memory screening in the community manual, and the page will come up. And on that web page, you'll see a link to the PDF version, and then there's also, they've converted the memory screen manual into sort of drop-down sections on the page. And so all the material is there for the memory screen, the community manual. The other thing I'll mention is that my colleague, Kristen Felton, the dementia specialist in our office, she is the one who created the memory screening manual, and so I'm sure she would be willing to answer any questions that you have about the tools, how she put together the manual, and trying to implement it in your area. And her contact information should also be on that webpage.
Great, thank you. Can both of you talk a little bit about, do you have any knowledge of workforce trainings to teach about people living with intellectual and developmental disabilities and dementia? And if you don't have them yourself, do you have any key places where you refer people?
This is Erin. I do not have that information off the top of my head, but I know that there is a group that has been doing some of that work out of the University of Illinois at Chicago. And Katelyn, do you have other information on that?
Yeah, this is Katelyn. So there's a great group and website to look into called the National Task Group on Intellectual Disabilities and Dementia Practices. You can also Google NTG, the National Task Group, and probably find it. Again, it's the National Task Group on Intellectual Disabilities and Dementia Practices. And they've been doing a lot of work in the intersection of intellectual disability and Alzheimer's disease. And two other resources that I'll mention is that I actually managed a grant that addressed IDD and dementia, and there were 2 toolkits that were created. One of them was specific to providers, medical providers, and diagnosing Alzheimer's disease in folks who have an intellectual or developmental disability, just because that procedure looks a little bit different than for the general population. So that toolkit was created by the Wisconsin Alzheimer's Institute, and if you go to their website, you should be able to find that toolkit on their website. Again, it's the Wisconsin Alzheimer's Institute. And they created a toolkit for diagnosing Alzheimer's disease in folks with intellectual disabilities. And then the second resource is really geared more toward people with intellectual disabilities and their family caregivers. And that was developed by the Wisconsin Board for People with Developmental Disabilities. Their acronym is BPDD, again, the Wisconsin Board for People with Developmental Disabilities. And that toolkit really helps provide some information about, the increased risk of people specifically with Down syndrome, the increased risk for Alzheimer's disease, and sort of how families can talk about it, how families can think about it, how they can sort of track the potential progression of a dementia in someone with intellectual disability, and how to provide ongoing care for that person. So those are 2 resources I can think, actually 3 resources I can think of off the top of my head.
Great, thank you. And there are also multiple resources on the NADRC website on IDD and dementia. I just sent out the link to all the participants for the Practical Strategies for Professionals handbook that we put together last year. It's called Intellectual and Developmental Disabilities and Dementia, Practical Strategies for Professionals. So there's quite a bit on the NADRC website. If you type in the search feature IDD, the acronym IDD, and then the word dementia, in addition to those resources that Katelyn just mentioned and that Erin referred to. So hopefully those can be useful to some of you. Let's see. We have another question that came in asking a little bit more about what you have been doing to conduct memory screenings with the DCS project during the current COVID-19 pandemic. Are you able to conduct those screenings over the phone? Have you had to adapt in any other ways? And Erin, I know a lot of your materials are online, but if you have any response to how you've adapted during the pandemic, that would be useful too.
Sure. So specifically related to cognitive screening during COVID, we have adapted to using the MOCA blind, the Montreal Cognitive Assessment blind version, which can be done over the phone and is validated for telephone use. There is also a 6-item screener by Callahan that came out in 2002 that if you Google it, it's easy to find. That is an adaptation of the mini mental. It's only 6 items, can be done over the phone, and so we have started using both of those, both in our primary care settings and then also in the hospital during COVID when our participants cannot interact physically with our materials. We've been using that and using those measures in the hospital setting as well. Have been doing a fair amount of telehealth and one of the other things that the GWEP is doing now, HRSA just gave each of the GWEPs an additional amount of money to address technology during COVID. And so one of the things we're going to be doing is developing some technological education programs for individuals to learn how to use devices And that's one of the biggest barriers. We've done some focus groups on the west side of Chicago, and they say, you know, my kids got me a tablet to use during COVID because I can't get out, but I don't know what the heck to do with it, and it terrifies me. So, and or folks who say, I don't have internet access, I don't have any of that kind of thing, so I can't do a number of the things that I would like to do, including sometimes getting groceries or other kinds of things. My caregivers can't come in, and so trying to build the technological capacity of caregivers, in particular, family caregivers in the home in particular, but also older adults directly to be able to access their telehealth portals and be able to do video visits and things like that so they can better get their health needs met, which going forward, particularly for individuals with dementia who find it difficult for the caregivers to get them out of the house and or just accessing health care, we envision to be sort of a critical need moving forward.
Great, thank you. Katelyn, do you want to talk a little bit about how you've adjusted during the pandemic?
Yeah, just briefly, actually very similar to what Dr. Emery-Tiburcio is doing. We are also using or suggesting that DCS use the MOCA for the blind. We also are able to use the AD8, which is a tool that the caregiver fills out. So that's another possibility, but we have mostly recommended using the MOCA for the blind. The challenge that our DCS have been finding is that, you know, the memory screening and the community piece of it is really a conversation starter, right? It's not a diagnostic process. It's really just to get the conversation going and talk about an individual's concerns about their memory. And many times when a DCS or another ADRC staff member does a memory screen, a lot of times it's in the home, and that staff member can sort of pick up on other cues or other issues that might be happening in the home and address those, you know, up front. And so when they're doing memory screening over the phone, it's still helpful to have that conversation, but the DCS, as we're finding, as we're working through the era of COVID, that, you know, they're not able to pick up on those other things that they would typically see in the home. So, you know, we're doing the best that we can with what we have, but it is a very challenging time.
Yes, I think we all can agree with that for sure. So, great. Well, we are just about out of time, so I want to thank everyone for attending today. This has been a really fruitful webinar with a lot of great information shared. Thank you again to our presenters, Dr. Erin Emery-Tiburcio and Katelyn Marschall. And I'm going to turn it back over to Betsy from the American Society on Aging for some final comments.
Thanks, Sari. We have reached the end of our hour, so it's time for us to wrap up. I'd just like to thank Erin and Katelyn for being here with us today. Thank you so much.
Thanks for the opportunity.
Yeah, thanks for having us.
Thanks, everyone, and hope to see you at our next webinar on August 27th. The registration information will be posted on the American Society for Aging website in the near future. Have a great day, everyone.